Good morning, ladies and gentlemen. First, I would like to thank the organizers for the invitation to present here on my favorite topic, and that is atrial fibrillation in adult patients with congenital heart disease. So, in grown-up patients with congenital heart disease, is atrial fibrillation a major problem? And if so, how large is the problem? Why do grown-up patients with congenital heart disease have a higher risk for atrial fibrillation? Do they have more triggers? Or do they have more extensive arrhythmogenic substrate? And what is the substrate or the mechanism underlying atrial fibrillation in this specific patient group? And finally, how should we treat AF? This table from the consensus document nicely shows that atrial fibrillation occurs in a variety of congenital heart defects and is associated with simple, moderate, and severe complex congenital heart disease. There's an increase in the number of patients with congenital heart disease presenting with atrial tachyarrhythmias. On the one hand, this is caused by an increase in the number of patients with congenital heart disease due to improved detection technologies, but also to refinement of surgical techniques and improved clinical care. And these patients are presenting with a variety of atrial tachyarrhythmias. These tachyarrhythmias include focal atrial tachyarrhythmias, intra-atrial-oriented tachycardias, and also atrial fibrillation. And atrial fibrillation occurs, as shown by these bars, mainly in the patients with simple congenital defects. Atrial fibrillation is associated with aging, also in the patient with congenital heart disease. Below the age of 20 years, the majority of the patients present with intra-atrial tachycardias, whereas over the age of 50 years, the majority of patients present with atrial fibrillation. When a patient with a simple congenital defect is at the age of 18 years old, he or she has a likelihood of 50% of developing atrial fibrillation at the age of 65 years old. On the right side of the slide, we can see for nearly 200 patients the age of the first documented AF episode plotted for each congenital heart defect separately. The average age of onset in this population was around 50 years old, and we can also see that in numerous patients atrial fibrillation developed already before the age of 40 years. When a patient with congenital defect presents with atrial fibrillation, it is most often the paroxysmal type of AF. But when this patient becomes older, it changes from the paroxysmal to the more permanent types of atrial fibrillation. Another observation is that episodes of atrial fibrillation also coexist with episodes of atrial tachyarrhythmias. In a population of nearly 200 patients with congenital heart defect, we observed that there was a coexistence of atrial fibrillation and regular atrial tachyarrhythmias in about 33% of the population. And these episodes of regular atrial tachyarrhythmias and atrial fibrillation are alternating without any medical intervention. In some patients, the first episode was atrial fibrillation, whereas in the other patients the first episode was a regular tachyarrhythmia. But there's a complex interaction between atrial fibrillation and atrial flutter. So imagine a patient with congenital heart disease initially presents with atrial fibrillation. Then you are treated with either antiarrhythmic drugs or a pulmonary vein isolation, and you may end up with atrial flutter. Atrial flutter itself induces remodeling, that is electrical remodeling, which consists of shortening of atrial refractoriness inverse rate adaptation, structural remodeling, and it also induces multiple areas of scar tissue. And this remodeling, again, induces the occurrence of atrial fibrillation. On the other hand, you can also have an atrial flutter, a typical caevo-tricuspid isthmus dependent atrial flutter. And that when that is ablated, you may still have episodes of atrial fibrillation comparable to patients without congenital heart disease. And these episodes of atrial fibrillation again induce remodeling, which consists of the electoral, structural, and contractile remodeling, and this further aggravates the fibrillatory process, and there's a progression of atrial fibrillation. We observed in nearly 200 patients that progression of atrial fibrillation is rather fast in this group. In our population, 26% of the patients progress from the paroxysmal form to the more persistent types of atrial fibrillation in less than 5 years. The development of atrial fibrillation requires both triggers and an arrhythmogenic substrate. So the first question is whether atrial extrasystolic beats are more often present in congenital heart disease patients with atrial fibrillation to compare to those without atrial fibrillation. And for this purpose, we had 573 patients with congenital heart disease. They were matched, and we analyzed the Holter recordings over time. And what we observed in this population is that the total amount of ectopic beats in the patients without atrial fibrillation was nearly 400 per day, whereas when the patients developed atrial fibrillation, the number of ectopic beats per 24 hours was over 2,000 per day. And there was also several determinants of atrial active beat. These included, as expected, aging, female gender, the presence of a univentricular heart, lower body mass index, valvular dysfunction, and also, not surprising, left atrial dilatation. So the arrhythmogenic substrate in this patient group consists of prolongation of atrial refractoriness and also of dispersion in refractoriness. There may be chronic bradycardia due to sinoatrial node dysfunction. There may be multiple areas of interatrial conduction delay, and there may be the presence of conduits, long suture lines, and areas of scar tissue. For many years, there is an ongoing debate on the underlying mechanism of atrial fibrillation, and the debate started already in 1959. The experiments of Moe demonstrated that atrial fibrillation could be caused by two different mechanisms. On the one hand, you could have a focus or a source which activates the atria at a high rate, and when the atrial tissue cannot follow in a one-to-one manner, there is a fibrillatory conduction. So the degree of fibrillatory conduction depends on the presence of a source. On the other hand, you may have true fibrillation, in which the atria are activated by multiple wavelets which are independently from each other. And then this process can occur in either the two-dimensional or the three-dimensional plane. But how are we going to blade atrial fibrillation? And to answer this question, I would like to share with you several observations. So here we see the timeline of the development of atrial tachyarrhythmias in a patient with a tricuspid atresia type 2B who received an atriopulmonary conduit. And she developed multiple tachyarrhythmias, but one of them was an atrial fibrillation. And when she arrived at the lab, we found an area of continuous electrical activation in the interatrial septum. And when we created a circular region around this area, atrial fibrillation terminated. A similar observation was made in another patient, and that was a patient with a transposition of the great arteries who underwent an arterial switch procedure. And here you see the EKG, which clearly shows atrial fibrillation. And on the right side of the slide, you can see an area of continuous electrical activity. And this area of continuous electrical activity was surrounded by an area of scar tissue. And we created some kind of exit zone. And so we created a linear lesion across the exit zone. And when we did that, atrial fibrillation terminated. So what do we know about the outcome of pulmonary vein isolation in patients with congenital heart disease? In 2015, we reviewed the existing papers so far on pulmonary vein isolation in patients with congenital heart disease, either at the cath lab or at the surgical room. And we found that the recurrence rate was quite variable because there was a variation in patient-related factors, including the underlying congenital heart defects, the presence of comorbidity and a time in AF comparable to patients without congenital heart disease, procedural related factors such as the mapping approach or the ablation technique used, and also follow-up related factors such as the frequency of monitoring or the monitoring device used. And I think that due to the rapid development in the mapping and ablation technologies, but also the technologies for continuous rhythm monitoring, we will continue to improve our ablation outcome and also the accuracy of the heart rhythm detection. I would like to show the outcomes of a recently published study, which was an international multi-center study on the outcomes of catheter ablation for atrial fibrillation in patients with congenital heart disease. And this study included 250 patients. And here you can see for the simple, the moderate, and the complex congenital heart defects that the 1 year of freedom of atrial tachyarrhythmias was between the 40 and the 50%. So why would the pulmonary vein isolation be effective in grown-up patients with congenital heart disease? Well, the first reason is for a very logical reason, because you isolate the triggers. I've just demonstrated that triggers occur more frequently in patients without congenital heart disease, so it might be logical to start with isolation of the triggers. But you do more than that. You may interrupt crucial pathways of conduction. You might modify the arrhythmiogenic substrate, whatever that may be. The atrium may be denervated or the atria may be debulked. But why would a pulmonary vein isolation not be effective? Well, first of all, there can be reconduction across the circular lesion comparable to patients without congenital heart disease. But there might also be triggers outside the pulmonary veins. And there are now already a few studies demonstrating that there are also triggers outside the pulmonary veins in patients with congenital heart disease. There may be an extensive arrhythmiogenic substrate. And also, it might be that atrial fibrillation is not a left-sided disease, but a disease originating from the right atrium. So I think we have more questions than answers. First of all, do triggers in patients with congenital heart disease originate mainly from the pulmonary veins? What is actually the definition of the arrhythmiogenic substrate? Where is the arrhythmiogenic substrate located? And can we already identify electropathology in pediatric patients? To answer these questions, we perform an interoperative mapping study of the entire atria in patients with congenital heart disease. For this purpose, we use a multi-electrode array containing electrodes with an inter-electrode distance of only 2 mm, and we shift this electrode according to a fixed schedule across the right atrium, left atrioventricular groove, and Bachmann's bundle. And in this study, we initially performed it in patients with atrial septal defect. So we demonstrated in patients with an atrial septal defect who did not have atrial fibrillation that the conduction abnormalities during sinus rhythm were mainly found at the right atrium and Bachmann's bundle. And here we see a preliminary data of a study we just finalized. And in this study, we had 3 different groups. So we had a control group, so that is patients without congenital heart disease. And then we had 2 groups containing patients with an atrial septal defect. And one group of patients had no history of AF, whereas the other group had a history of AF. And what we can see that in the patients with an atrial septal defect who had atrial fibrillation, the degree of low voltage areas particularly increased in the left atrium. So it might be that initially your electropathology in patients with an atrial septal defect originates in the right atrium, but if it progresses over time and goes and extends to the left atrium, atrial fibrillation may develop. This observation also raises the question whether atrial conduction abnormalities are already present in a patient with an atrial septal defect at the moment when they are born. So we performed in 10 patients with either an atrial septal defect and or a ventricular septal defect mapping of the right and left atrium and Bachmann's bundle. And we demonstrated that in these patients, atrial conduction abnormalities were already found at the right atrium and Bachmann's bundle. And we know that this is abnormal because we have data from adult patients with W-POW syndrome who were operated on already many years ago, and we know that in this historical data set, atrial conduction disorders were not present, whereas we do find them in the newborn patients with congenital heart disease. Finally, I'd like to show you this patient. I think it's a very intriguing patient. It's a 40-month-old patient with a short QT syndrome who presented with atrial fibrillation and went to cardiac surgery. And we took the opportunity to perform mapping of the right atrial free wall in this patient. And you can here see the unipolar electrograms recorded from the middle of the right atrial free walls. And the electrograms are at a distance of approximately 2 millimeters, and what you can see here nicely is that the cycle length of atrial fibrillation can be as short as 25 milliseconds. And I think this is really an amazing observation, because imagine if you have a cycle length of 25 milliseconds, how short the refractory period. So what is the take-home message? Well, first of all, atrial fibrillation is a major challenge in patients with congenital heart disease. Atrial fibrillation is predominantly paroxysmal in nature. With aging, there's a progression from paroxysmal to permanent atrial fibrillation. There's a coexistence of regular atrial tachyarrhythmias and atrial fibrillation. And these episodes are alternating. If progression of atrial fibrillation occurs, it occurs fast, and this justifies aggressive therapy. The pathophysiology of atrial fibrillation is mainly unknown. The role of the pulmonary vein isolation procedure is still debatable, and I think that additional strategies should be developed. I would like to thank you for your attention.